Hello, everyone. Welcome to the Department of Medicine Grand Rounds. We'll have time for questions at the end, so if you're on Zoom, please submit your questions in the Q&A, and we will answer those at the end. We'll also be presenting the 2025 William J. Bremner Endowed Mentorship Awards at the end, so please stick around for that. I'm pleased to introduce our speaker for today, Dr. Kathleen Ramos. Dr. Ramos is an associate professor of medicine at the Division of Pulmonary and Critical Care and Sleep Medicine at the University of Washington. She's the director of the Adult Cystic Fibrosis Therapeutics Development Network, or TDN, site at the University of Washington and serves as the medical director at the CF-TDN Coordinating Center. Dr. Ramos is a physician scientist with a master's in epidemiology and has experience conducting research using national registries to evaluate clinical outcomes for people with CF and for lung transplant recipients with underlying lung diagnoses. She has used community-engaged methods in study design and in the development of interventions. Dr. Ramos has a research interest in equitable access to clinical trial participation and has experience working alongside communities typically underrepresented in clinical trials. She is nationally recognized for her work in advanced CF lung disease and access to lung transplant for individuals with disadvantaged backgrounds. Her work is funded by the CF Foundation and the National Institutes of Health. Please welcome Dr. Kathleen Ramos.
Thank you, Anna, for the introduction, and thank you for the invitation to speak today. So I'm going to share with you cystic fibrosis care in a new era, triumphs of research and the road ahead. Skipped them. These are my disclosures here. So the outline for today, I'll talk about CF diagnosis and clinical features, the changing epidemiology and clinical management, and a new era in CF care and research. CF is an autosomal recessive genetic disease caused by variants in the CF transmembrane conductance regulator protein gene. Almost 4,000 variants have been identified in the CFTR gene, some with virtually no CFTR protein function and others associated with residual CFTR function. The CFTR protein is a chloride and bicarbonate channel that's found throughout the body, and the most clinically meaningful sites expressing CFTR include the lungs, sinuses, and GI tract, including the liver and pancreas. CF affects approximately 40,000 people in the United States, and the risk of having a child with CF varies by ancestry, race, and ethnicity. The risk for having a child with CF, if you're white, is 1 in 5,000. If you're Hispanic, it's 1 in 10,000. If you're Black or African American, it's 1 in 15,000. And if you're Asian, it's 1 in 40,000. Although CF was originally pathologically described in the pancreas, multi-system clinical manifestations are common. CF impacts the sweat glands, sinuses, the liver, the intestines, including distal intestinal obstruction syndrome, and in babies, meconium ileus, the reproductive system with congenital bilateral absence of the vas deferens, yielding infertility in greater than 95% of men, and also exocrine pancreatic deficiency and CF-related diabetes, and chronic airway infection and inflammation. Most patients with CF will die from progressive respiratory failure or undergo lung transplantation. Most cases of CF are identified by a newborn screening. Newborn screening has been universal in the United States since 2010 and in Washington State since 2006. This chart shows the age at diagnosis for all of the individuals with CF who were seen at a CF care center in 2024 and shows that approximately 75% were diagnosed by 1 year of age and 90% of individuals were diagnosed before 16 years of age. Sweat chloride testing is the gold standard for CF diagnosis. Pilocarpine and mild electrical current are applied to a small area of skin to stimulate the sweat, and the setup is shown there in panel B, what it looks like in practice. And the sweat is collected using the little device that's shown in panel C to determine whether the sweat chloride concentration is abnormally elevated. Sweat chloride values that are less than 30 are normal. Between 30 and 59 are borderline or indeterminate, possibly indicating CF, and values of 60 and over are diagnostic for CF. There's a correlation between sweat chloride values, the genotype, and phenotype. And in the absence of genetic information, the sweat chloride concentration can actually be used as a surrogate for mutation class. And patients who are homozygous for the severe mutations of the CFTR gene typically have concentrations of sweat chloride that are 90 or greater. Another way to diagnose CF is through genetic testing, and if two pathogenic CFTR variants are identified, that confirms the diagnosis of CF. Full CFTR gene sequencing is used when initial targeted panels are negative, and this can detect rare or novel variants. A lot of clinical labs limit their initial genetic testing of CFTR to a certain number of variants, 23 variants, 100 variants, and like I said, there are 4,000 variants that have been identified. If ordered at UWMC, the whole genome sequencing of CFTR is the initial genetic test that is performed. The most common CFTR variant in the United States is F508del, and approximately 85% of people with CF in the United States have at least one copy of that variant, and no other variant is found in more than 5% of the US CF population. There is variability by race and ethnicity, and people with CF who are either Black or Hispanic are less likely to have the F508del variant, and that can impact their access to transformative CF therapeutics. It's worth discussing the CFTR mutation classes and defects as they have implications for these newer CF therapeutics that we'll talk about today. So class 1 mutations include a premature stop codon and no functional CFTR protein is made. These mutation names always contain the letter X, and so that's how you can tell that it's a stop mutation. The class 2 mutations include an amino acid deletion, which leads to a trafficking defect that causes the protein to be degraded, and then no functional CFTR protein reaches the cell membrane. F508del is a class 2 mutation, and it's the most common CFTR mutation in the US. Class 3 mutations lead to a defective channel regulation or a gating mutation where CFTR reaches the cell membrane, but it won't conduct chloride or bicarbonate. It doesn't open. The G551D mutation was the first one to be targeted for CFTR modulator therapies. The class 1 to 3 mutations are all severe. So those first 3 I just described lead to a severe phenotype of CF. The class 4 mutations have residual function, but they basically yield decreased channel conductance. Not as much goes through the channel. And then class 5 mutations are due to splicing defects, and they yield a reduced amount of normal CFTR. And then finally, a newer class that's been described is this class 6, which is reduced CFTR stability due to increased CFTR recycling. And there's a thought that people on modulators may have some element of this class of dysfunction. So I want to share a case presentation, which is atypical because the typical presentation is in babies, but this is a case of a 63-year-old woman with a lifetime of recurrent pulmonary infections and low BMI who's hospitalized with Pseudomonas pneumonia and respiratory failure, and her CT chest revealed bronchiectasis and mucus plugging. After she recovered from her intensive care stay, a pulmonologist performed a thorough bronchiectasis workup. Her sweat chloride was 66 millimoles per liter, and as I mentioned, it's diagnostic if it's 60 or higher. And her CFTR genotype was F508del R117H. We are more frequently seeing adult diagnosis of CF, but it remains rare. And often people who are adult diagnosed have at least one copy of a less severe CFTR mutation class. But diagnosis and genotyping can yield access to highly effective therapeutics. So it's worth looking for CF if you have a patient who has bronchiectasis and potential manifestations of CF. So now I want to talk about some of the changing epidemiology and clinical management. I'll share some early CF milestones. In 1938, Dr. Dorothy Anderson published the first description of cystic fibrosis, and the name was actually based on cystic fibrosis of the pancreas, based on autopsy specimens of young children who were dying of the disease. In 1955, the Cystic Fibrosis Foundation was formed by a group of concerned parents who wanted to improve outcomes for their young children who were dying from this disease. In 1961, the CF Foundation established a CF Care Center network, which started out as just 2 institutions that were caring for people with CF in a specialized way. And at that time, median survival with CF was only 10 years. In 1966, the CF Foundation launched the Patient Data Registry, and at that time it was a paper form that was filled out for any patient who was seen at the care center during the year, and it was physically mailed to the CFF for collation, putting them together. And at this point, it's all collected electronically, and we capture data on every encounter that a person with CF has at your care center, and an annual form that has 300 data elements to input. And so that registry is a really robust resource for both care and research for people with CF. In 1989, the CFTR gene was identified, and at that time, median predicted survival was in the late 20s. And in 1998, the CF Therapeutics Development Network was established to bring together specialized clinical research centers to conduct multi-center clinical research in CF. So much of what is being done to advance CF care and research really relies on the CF Therapeutics Development Network, or TDN. And what started as 7 CF centers working together on early CF clinical trials has evolved into a network of 80 specialized research centers across the United States, represented by the yellow dots on the map. The TDN Coordinating Center is here in Seattle, Washington. It's led by Dr. Chris Goss in the UW Division of Pulmonary Critical Care and Sleep Medicine, right here, and Dr. Nicole Mayer-Hamblett in the UW Department of Pediatrics and at Seattle Children's. So with new diagnostics and therapeutics, predicted survival improved over time. And so this figure shows some additional milestones along with the therapeutics developed at those times and the median predicted survival on the y-axis. So as I mentioned, 1938 was when the first pathological description occurred for CF, but it wasn't until 1948 that they discovered there's high salt in the sweat. And it was another 11 years before the sweat chloride test was actually developed. And during that time, pancreatic enzymes, airway clearance, anti-staphylococcal antibodies, anti-pseudomonal antibiotics, all came into existence development. In the 1980s, the CF protein was identified and lung transplant started to be a treatment option. In 1989, the CF gene was identified, and there were trials after that for recombinant human DNase or Dornase alpha, as well as inhaled tobramycin. And then by 2010, like I mentioned before, newborn screening became universal. And so you can see that therapeutics evolved over time, but they're all targeting sort of the downstream effects of CF, the CFTR mutation. I do want to talk to you about the pathophysiologic cascade in CF and where the therapeutics act in treating CF. So the CFTR gene mutation leads to a defective or deficient CFTR protein, which leads to defective ion transport of chloride, bicarbonate, and sodium. This leads to airway surface liquid depletion in the lungs and acidic airway surface liquid, and that yields defective mucociliary clearance and impaired bacterial killing. This leads to the vicious vortex of airway obstruction, infection, and inflammation. And as I was mentioning, the therapeutics to date had really been mutation-independent therapies that focused on the downstream effects and included mucolytics, chest physiotherapy, bronchodilators, anti-infectives, and anti-inflammatories. But now there are mutation-dependent therapies, which are the CFTR modulators. So to focus on CFTR modulators for a bit, high throughput screening identified ivacaftor as a potential CFTR modulator, and in vitro assays from cultured human CF bronchial epithelial cells carrying the G551D mutation gave biologic plausibility data for ivacaftor use in CF patients. The in vitro assay showed that ivacaftor increased chloride transport to 50% of normal CFTR protein, and this is thought to correlate to a substantial in vivo effect. So it was then studied in a randomized controlled trial in people with CF, and ivacaftor improved lung function, exacerbations, weight, and quality of life in people with the G551D mutation. Dr. Bonnie Ramsey from UW and Seattle Children's conducted this pivotal randomized controlled trial of patients who were at least 12 years old with at least one copy of the G551D gating mutation. And ivacaftor led to an absolute improvement in FEV1 of 10.6% of predicted, a decrease in exacerbations by 55%, and a decrease or improvement in the sweat chloride by 48.1 millimoles per liter. These changes were rapid within 15 days of starting the trial, starting the medication, and they were sustained over 48 weeks. And while this was a home run therapeutic, incredibly effective, it was only 4% of the CF population who were eligible but based on the mutations for this therapeutic. So the next focus was really CFTR modulators for the F508del mutation. Do you need to? How can I be centered? Stand here. Okay. Minor technical adjustment. So next focus was CFTR modulators for the F508del mutation, for which a much larger population would be eligible. And as you recall, F508del is a class 2 mutation, and that requires a combination of CFTR modulators, both a corrector and a potentiator. The correctors restore trafficking of the CFTR protein up to the cell membrane, and the examples include lumacaftor, tezacaftor, elexacaftor, and vanzacaftor. And then the potentiators make the CFTR protein functional. So it sort of opens the gate or opens the channel and makes it work. And examples there are ivacaftor and dute-ivacaftor. So tezacaftor ivacaftor was actually the second CFTR modulator, and it was approved for people with F508del homozygosity. The first one was lumacaftor ivacaftor. So tezacaftor ivacaftor improved exacerbation frequency and modestly improved the FEV1. In the RCT that included 510 people with 2 copies of F508del, there was an increase in FEV1 by 4% predicted, and a decrease in exacerbation by 35%. Elexacaftor, tezacaftor, ivacaftor, which I will call ETI from now on, was the next generation of CFTR modulators, and it's a triple combination therapy with 2 correctors and 1 potentiator. And ETI markedly improved the FEV1 for F508del homozygous patients with an absolute improvement in FEV1 of 10% above Tez-Iva and a sweat chloride reduction of 45.1 millimoles. But what's even better news is that ETI was also effective for people who only had 1 copy of the F508del variant. And so in the RCT of 403 patients with F508del and a minimal function variant, so another gene that was more severe, there was an absolute improvement of FEV1 by 14.3%, and a decrease in exacerbations by 63%. And so these patients had never had access to a CFTR modulator in the past. And if ivacaftor for G551D was a home run, ETI was a grand slam. Really knocked it out of the park. As of December 2024, 76% of people with CF were on ETI, and only 6% were ineligible for CFTR modulators by genotype. Also in December of 2024, there was another triple combination CFTR modulator that was approved. It's called vanzacaftor, tezacaftor, dute-ivacaftor, VTD, which is very similar to ETI, but has once daily dosing. So the median predicted survival is increasing, and this figure shows the median predicted survival on the y-axis and the 5-year increments for both birth cohorts on the x-axis. So a child born between 2000 and 2004 was predicted to have a median survival of 34 years, whereas a child born between 2000 and 2020 between 2020 and 2024 has a median predicted survival of 65 years old. And that's largely related to these major changes due to ETI. But this estimate actually does not reflect future care and treatment innovations that could increase survival further. So I think we're probably underestimating how long these new babies will live. But it's also important to note that the median predicted survival is lower, maybe by a decade or more, for people who are ineligible for CFTR modulators. And the median age at death in 2024 was 38.8 years. So people are still dying young with CF, and 40% of the deaths occurred in lung transplant recipients with CF, but 60% occurred in people who did not have lung transplants. Trying to be patient. Okay, so I want to pause and take a moment to talk about equity and access to CF clinical trials. People with minoritized race and/or ethnicity are underrepresented in clinical trials compared to the composition of the entire CF population. And their lack of representation in the clinical trials leads to decreased early access to breakthrough therapeutics like the CFTR modulators. It also leads to therapeutics with untested efficacy and safety in these marginalized groups and mistrust of the therapeutics among those who are excluded from the research. People with CF with minoritized race and/or ethnicity are less often eligible for highly effective CFTR modulator therapies based on their genotype. And Dr. Tiana Milanich in our Division of Pulmonary Critical Care and Sleep Medicine has CF Foundation funding to explore the barriers and facilitators to inclusive enrollment in CF research, and is going to co-produce an intervention with CF community members to improve equitable CF clinical trial enrollment. Also, work done by Dr. Tiana Milanich and our group has shown that lung transplant for CF is decreasing. So this figure here shows the number of CF transplants per year on the left-sided y-axis, the calendar years across the x-axis, and then the proportion of all US transplants that were for CF on the right-sided y-axis, and that's represented in the orange line. And what you can see is that between 2011 and 2018, CF transplants made up 10 to 12% of the transplant volume in the United States, and it was the third most common indication for lung transplant. But after the approval of ETI in October of 2019, there was a dramatic decrease in the number of lung transplants for CF, and that has been sustained, and there were fewer than 50 lung transplants for CF in 2024. So getting back to our case presentation, we learned that her FEV1 was only 34% of predicted, and her BMI was 17.5 after she was discharged from the hospital. She was eligible for triple combination CFTR modulator therapy, ETI, which led to improved FEV1 and BMI. Unfortunately, despite highly effective CFTR modulator therapy, she went on to require lung transplant. So I wanted to share some new unpublished data that we have related to the modern era of CF lung transplant recipients. We used the Scientific Registry of Transplant Recipients, or SRTR dataset, that's the US National Transplant Registry, to identify all first-time lung transplant recipients with CF in the United States. So we excluded the retransplants. And we have follow-up through August 31st of 2025. We leveraged a linkage of the SRTR with that robust CF Foundation patient registry data to determine whether or not people were on ETI prior to their lung transplant. And we identified this CF transplant cohort in the post-ETI era for people who were transplanted between January 1st of 2020 and December 31st of 2023. And so this table shows the demographics of those on ETI versus not on ETI. And there are 179 people who had data in both of those data sets. And about 50% of the transplant recipients were on ETI at the time of their transplant. And among those who were not on ETI, they tended to be slightly younger, were less often white, were more often Black, had a similar prevalence of Hispanic ethnicity, and had a much higher rate of no copies of F508del, which makes sense based on eligibility for the modulators. There were no significant differences identified in insurance status, patient's educational status, the functional status at lung transplant, or markers of disease severity at the time of transplant. But given the shift in demographics towards older and more diverse patients and the fact that there are fewer transplants being performed, the CF and transplant communities have wondered about changes in post-transplant survival in this modern era. So we performed Kaplan-Meier estimates of post-lung transplant survival in the modern era by pre-transplant ETI status. We found no difference in survival among those on ETI versus not on ETI prior to their transplant. And if you can see in the lower box there, the 1-year survival for those who were not on ETI was 95%, and those on ETI, it was 88%. And looking back to 2019, the 1-year survival for all people with CF, none of whom were on ETI, was 89%. And so in summary, the post-lung transplant survival is similar in the modern era of CF therapeutics and therefore should be considered a good treatment for end-stage CF lung disease when it's indicated. So the next step in the outline here is to talk about the new era of CF care and research. And it's a very different disease now with the symptoms that patients have and the quality of life that patients have. So CF exacerbations are a common clinical manifestation of CF, which many of you may be familiar with. And exacerbations are decreasing in frequency. Prior to the approval of ETI in October of 2019, approximately 45% of adults that are represented in that dark blue line had at least one course of IV antibiotics each year or in that year. But this has fallen to only 15% of adults with one or more IV antibiotic courses in 2024. And so there's been a very dramatic reduction in the use of IV antibiotics. The STOP program, or Standardized Treatment of Pulmonary Exacerbations, is funded by the CF Foundation, and the trials within the STOP program have been run through the CF TDN and with Dr. Chris Goss from the UW as the national PI. So STOP2 assessed IV antibiotic treatment duration in 18 years and older CF patients. It was conducted in 58 sites across the US and Canada and enrolled patients between July 2016 and January of 2020. The trial randomized patients after 7 to 10 days of IV antibiotics based on their initial response to the antibiotics. And so people who had an early robust response, which was defined as an 8% improvement in their FEV1 or an 11-point improvement in their quality of life score, the CRIS score, were considered early robust responders, and they were randomized to 10 or 14 days of antibiotic therapy. The people who were not early responders or early robust responders were randomized to 14 versus 21 days of IV antibiotics. They were stratified by their percent predicted FEV1, their history of pulmonary exacerbations in the year prior, the location of the IV antibiotic treatment, and steroid use by the time of randomization at 7 to 10 days. And the primary endpoint was percent predicted FEV1 change from the IV start to 2 weeks after the end of their IV antibiotic treatment. And what was found is that in the early robust responders, 10 days is non-inferior to 14 days. And in the not early robust responders, 14 days is non-inferior to 21 days. And so based on these data for the early robust responders we see clinically, people who feel better, their symptoms have improved dramatically, and their FEV1 is improved by 7 to 10 days after starting antibiotics, it is reasonable to stop antibiotics at 10 days. Stop 2 did not show that 10 versus 21 days are equivalent. It compared 10 versus 14 and 14 versus 21 in 2 separate cohorts of patients. Based on the STOP2 results, however, future clinical trials can standardize the antibiotic treatment duration for pulmonary exacerbations to 14 days. And the STOP 360 AG trial is a large multi-center randomized controlled trial within the CFTDN led by Drs. Chris Goss and Patrick Flume. And it's evaluating the safety and efficacy of a 14-day antibiotic regimen with and without IV aminoglycosides to treat pulmonary exacerbations in Pseudomonas infected people with CF. And the study includes a large proportion of individuals who are on CFTR modulators to inform contemporary clinical care. So thinking about Pseudomonas aeruginosa, which is that blue line, the light blue line on the graph, there's been a decrease in prevalence over time, even before highly effective modulator therapy was widely available, which was likely due to a combination of factors, including a focus on eradication at the time of initial acquisition. But since 2019, there's been a more dramatic decrease in Pseudomonas that is also likely multifactorial, but in part due to better mucociliary clearance and host defenses in the setting of highly effective modulators, but also decreased detection because people with CF produce less sputum now on highly effective modulators. So the CF-TDN study PROMISE was a multi-center prospective observational study of people with CF before and after initiating ETI. There's a microbiology sub-study, and in that sub-study, sputum samples were assessed for Pseudomonas density before ETI and then up to 4.5 years after ETI. And they found that 70% of Pseudomonas infected participants remained colonized after ETI, and the sputum Pseudomonas density decreased only minimally in these participants. And these data are courtesy of Dr. Pradeep Singh. So addressing the challenge of identifying pulmonary infection is important to the CF community, and sputum culture is the current standard for diagnosing pulmonary infection in CF, but highly effective modulator therapies have reduced the volume of sputum, and some individuals do not spontaneously expectorate. Cell-free DNA could be used to detect plasma microbial cell-free DNA in the blood. Dr. Steve Salaponte and his group conducted a study of 15 people with CF and 20 people without CF, where they drew blood and conducted this cell-free DNA extraction, and then they performed next-generation DNA sequencing. They also collected a sputum culture from the people with CF. They found that 10 out of 10 culture-positive patients had significant positive Pseudomonas cell-free DNA levels relative to the unaffected donors, and 6 out of 6 culture-negative patients did not have significant cell-free DNA levels. And so they have identified the optimal procedures and bioinformatic approaches for distinguishing Pseudomonas infection positive versus infection negative people with CF using this blood test. And there's ongoing work related to that. So with people with CF experiencing fewer symptoms, less cough, less sputum, less dyspnea, they're coming to clinic less often. The CF Foundation has recommended quarterly CF clinic visits for decades, but the care model is definitely shifting now. Before the highly effective modulator therapy era, approximately 40% of adults in the dark blue had quarterly visits into the CF clinic. So we weren't at 100% before, but 40% were seeing us 4 times a year. And that has fallen to 20% of adults in 2024. And before highly effective modulator therapy, 80% of adults had at least 2 CF clinic visits per year, which has fallen to approximately 60% in 2024. So many people with CF are only being seen once a year in CF clinic. So adults with CF have their CF-related issues, but they also have aging-related issues. And the US CF Foundation projections show that the adult population will grow to exceed 70% of the total CF population by 2040. And it's currently about 60% of the total US population. And it's really striking thinking about how this was a disease of childhood. People were dying when they were not even getting to kindergarten. And so now more than half of the population are adults. This is not going forward. Okay. Many manifestations of CF will worsen with age and or post-lung transplant. And the CF teams are managing diabetes, hypertension, hyperlipidemia, obesity, because CFTR modulators help people with CF gain weight and sometimes too much, mental health issues, chronic kidney disease, osteoporosis, and cancer risks. Given the decrease in symptoms and sputum production, questions have come up around chronic mutation-independent therapies, things like inhaled antibiotics, hypertonic saline, Dornase alpha, and many of our patients were actually telling us that those therapies don't help anymore. And so Simplify was a randomized controlled trial conducted within the CF-TDN that assessed discontinuation versus continuation of hypertonic saline and or Dornase alpha in CFTR modulator-treated people with CF. So the change in percent predicted FEV1 is shown for participants who either discontinued versus continued each of these 2 therapies, and it was shown that it was non-inferior to stop these therapies. There were a few caveats to this trial. One is that the participants were very healthy. They had a mean FEV1 of 97% of predicted, and the study duration was only 6 weeks long. And so extrapolating that to stopping forever is extrapolating. There have been some unintended consequences as well, because many people with severe disease have also discontinued these therapies, and we don't have evidence yet to support doing that. The number of pregnancies per year has doubled since the availability of ETI, and that is likely because people feel better, but also because the cervical mucus is likely thinner on the highly effective modulator therapies, and that may have been contributing as a barrier and producing some subfertility in women with CF. There's also interest right now in utero treatment of a fetus with CF. So CFTR modulators are available for children as young as 1 month old. Ivacaftor is available to that age, and ETI is available for children 2 years and older. Research in CF ferrets has shown that in utero treatment with ivacaftor for the G551D homozygous animals reversed the GI complications, including meconium ileus and pancreatic insufficiency. And it led to fertile male kits, the baby ferrets, with intact vas deferens. So that is life-changing if you can actually make it so that males with CF are not infertile. And there have been case reports and case series of pregnant non-CF women taking CFTR modulators to treat meconium ileus in a fetus with CF, showing resolution of the meconium ileus with modulator treatment. One of the problems is, though, when the baby is born, they don't have access to the therapies anymore. And so that's one issue. And getting insurance approval to cover the treatment is another issue. There's ongoing research within the CFTDN looking at the safety of CFTR modulators in pregnant women with CF, and that's Mayflowers. We've been participating in that study for years now. And there's a new trial in the CFTDN that will evaluate the PK, the pharmacokinetics of CFTR modulators, and the outcomes for babies who are treated in utero with carrier moms, and that's called PROTECT. One other major area of interest for the CF Foundation and CF community is gene therapy for CFTR modulator ineligible or intolerant individuals. A subset of people with CF do not benefit from CFTR modulator therapy. And several approaches to gene therapy for the lungs are under active investigation. Adeno-associated virus, which is a small non-pathogenic viral vector, is being used to deliver DNA to the cells of the lungs through nebulization. mRNA in lipid nanoparticles, much like the COVID mRNA vaccines, is also inhaled, and then the mRNA is delivered to the cells in the airways. And then lentivirus is an integrating viral vector, more long-lasting, like herpes virus, is another way that DNA is being delivered to the cells of the airway. There have been major issues with delivery of the corrected gene to the lung because it causes a really big systemic inflammatory response, and there have been cases of acute lung injury from inhaling these therapies. And unfortunately, inhaled gene therapy will not provide systemic benefit like CFTR modulators do. It'll only affect the lungs. UW is participating in 2 CF gene therapy trials. This is our team going into the room the day that we gave our first dose of the first gene therapy. That was in June of 2024. I mean, they had done gene therapy here decades ago with Dr. Moira Aiken and Chris Goss, but this is of the new era of gene therapies. This is the first person. We've enrolled 3 people with CF to date, and we are relying on regional collaborations to identify participants for the gene therapy trials because they're actually really rare people who are eligible. So in conclusion, CF is primarily diagnosed in newborns, but it can be identified in adults. CF affects people of all races and ethnicities. CFTR modulators have changed the landscape of CF care, but people still die young, and they may require lung transplant despite CFTR modulators. The new CF involves fewer symptoms and less treatment burden for people who are eligible for modulators. CF research is now focused on identifying treatments for CFTR modulator ineligible or intolerant individuals, and also in determining best practices in the setting of highly effective CF therapeutics. And then finally, the CFTDN is a tremendous resource that has been key to many of the triumphs in CF research, and it will help the CF community navigate the road ahead. I have a thank you slide with a lot of names on it, but I want to especially say thank you to Chris Goss and Sid Kapnatic for reviewing my slides and helping me make a better presentation, as well as the CF clinical team, CF research coordinators, and the coordinating center. And that's my daughter and our brand new little puppy that we got at the end of December, who joins me on many Zoom calls. Not today. And thank you for your attention. And here is a QR code to do an evaluation if you're willing. It's helpful for promotion. Thank you.
Hey, that was a great talk. Oh, yeah. Kathy, that was a great talk. I'm curious, in the era of the next personalized medicine. So for the past 100 years, we've had these large randomized trials. We have groups of large people. And with this personalized medicine, like in this gene therapy, how do you design studies for that? Because there's not really like, placebo group? How do you assess efficacy? How does the FDA like decide whether it worked or not?
Yeah, that's a great question. I'm going to repeat it for the people on Zoom to hear. So Dr. Morell asked, for the past, 75, 100 years, there have been large clinical trials and large populations available for those clinical trials. But when you're looking at something like gene therapy, where there are few possible participants, how do you design something where you can actually show efficacy, and do you use placebo? So the CFTDN is thinking really hard about this right now, and they actually created an observational study called REACH, and I can't remember right now what the acronym stands for, but it's basically enrolling people who are not on CFTR modulators, who are ineligible for CFTR modulators, and having them do study procedures without an intervention over the course of a year, quarterly over the course of a year. And they're collecting PROs, spirometry, even multiple breath washout to get their lung clearance index. And they're doing the data collection in a prospective and rigorous way, as if it was in a clinical trial, to try to create a pool of external control data. And people are able to leave REACH study to go do a gene therapy trial if they're eligible and they want to do that. But the CFTDN is working right now. Dr. Nicole Mayer-Hamblett is sort of leading this charge, working with the FDA to try to make sure that we meet all the benchmarks that they'll require for external controls. And then there are all these other trials that have had placebo groups from which you could pull potentially other external controls. And you still need to have some number of placebo patients within these trials as well, likely, but they're trying to make it so that we need fewer of the placebo patients.
So it's almost like a natural external.
Yeah, contemporary controls, more or less. So with data collection that's clinical trial level data. So, Chris, are you going to add anything to that?
No, that's a great response. It is challenging to use external controls. A lot of gene therapy trials of existing approved gene therapy trials, you'll see the studies. Some of them will have 15 patients,
yep,
20 patients, because they're often in rare genetic diseases. And then what they'll do is the FDA will require a post-approval follow-up and prescription to ensure the safety of the therapy.
Thanks, Chris. Did you have a question?
I have a very prosaic question.
Okay.
A channel corrector are not cheap.
Oh, yeah.
They just have insurance afford. Are there programs to CF Foundation provide drugs to people who are not financially in a position to afford?
Yeah, so the question was from Dr. Lyles, how do people who are uninsured afford CFTR modulators? They're very expensive, about $350,000 a year for this therapy. It's really, really bad to not have insurance with CF because it is an expensive disease that requires a lot of treatments. And there are compassionate use programs, and the CF Foundation has a program called Compass where they try to connect people with resources. But we see gaps in ETI for people who lose their insurance or their insurance changes. And Dr. Goss and his student, Alex Pitchler, are working on looking at what happens during gaps in ETI therapy that is frequently because of insurance loss. People just can't afford it.
And then I have a biologic question. Why do people on ETI therapy gain weight? I mean, they must increase absorption.
Yes.
Or maybe their appetite improves. But I would think the fibrotic changes in the guts of the pancreas would not correct too well when they start ETI therapy.
So this next question is, why do people on ETI gain weight? And the proposed ideas were, they have better absorption. Yes, that's what we think for sure. And there was a question of whether the pancreas, fibrotic changes in the pancreas, they probably won't get better. Well, actually, there's some evidence that maybe pancreatic insufficiency gets like a little bit affected, and people need fewer enzymes than they used to need when they're on highly effective modulator therapy. I think another major component is there's a reduction of inflammation and a reduction of the caloric expenditure from the infections in the lungs. And so much like you see post-lung transplant, when you take out the lung abscesses and then they don't have that infectious burden, they gain weight as well. So that's part of it. And I also have heard people talk about not feeling full, like they don't have the same amount of satiety as they used to have before modulator therapy. And so, but even independent of caloric intake, there's weight gain associated with the modulators. So anyway.
Yeah, and there's a study ongoing in mice looking at CNS, the gut-brain axis, in CF mice and non-CF mice, what Trikafta does when it's injected into the third ventricle, and it actually drives appetite pathways. So there may be also a direct effect of Trikafta, either through CFTR or independent of it, that stimulates appetite to help it. But the rate of obesity is shot up in CF.
Yeah, much
like
higher.
A third of the population.
Yeah, it used to be that we were worried about they're too thin, you have to eat and gain weight, and now we're hold off. Should we be thinking about GLP-1 medications in CF because they have diabetes as well? So anyway, yep, great. Yes, excellent. Shall we stop sharing here? Oh.
Great talk. I was just wondering, what are you guys doing with people who get lung transplant and have, non-CF lung epithelium and brain cells, non-CF lungs?
Yes.
And what do you do with their modulators? Did you continue with this modulator have any effect on normal CFTR in those lungs? Yeah, what do you do?
Oh, I love this question. Thanks for asking, Pradeep. So he asked, what do you do with the ETI among people who get a lung transplant? And what I will say is that because they no longer have CF in their lungs, but they have CF in the rest of their bodies. And so this is an area that I've spent some time studying, and it's really heterogeneous. There's heterogeneity in what people are doing. I think the default is that people are stopping the ETI at the time of lung transplant, but people have rebound sinus symptoms and then the gut symptoms, even in the early postoperative period, can be difficult to manage when there's high opiate use, there's the risk for DIOS, and there's some evidence that people who take ETI post-lung transplant get benefit to their sinus symptoms and their gut symptoms, and maybe their diabetes management as well. The prevalence of diabetes goes up quite a bit after lung transplant. But there's a question mark that I have about the safety for their lung allograft. And there are lots of case reports where the FEV1 will go down when people start ETI post-lung transplant. And the mechanism of that is not clear, whether it's overstimulation of normal CFTR in the non-CF lungs. That's one hypothesis. If there's a change in the immune response to the allograft because you're correcting the CFTR in the immune cells and the white cells, that's another hypothesis, but we don't really fully understand whether it's completely safe to be using ETI after lung transplant. And so I've been advocating for a long time that we should study it in a randomized controlled trial, but Vertex has no interest in doing that because all they'll get are adverse events, and it really is not going to be a big population for them to sell more drugs to. So for now, it is clinician dependent and completely wild, wild west. But yeah, thanks.
All right. So I'm here to introduce and present our 2025 William J. Bridner Endowed Mentorship Awards. And these awards are to recognize that mentorship is critical to the success of all phases of faculty members' careers. And in 2015, these awards were created to honor faculty members for their contribution to the scientific, educational, and patient care mission of the department through exemplary mentorship. And we select 2 individuals each year. We solicit nominations from all the divisions, and then a committee meets and we select 2 individuals to receive these awards each year. So 2 awards are presented, and the recipients receive not only a certificate that I will give them here, but also $2,500 that goes into an academic fund that you can use for scholarly activities. And in 2018, there was an endowment set up for these awards and to honor Dr. William J. Bremner, who served as our chair of medicine from 1998 to 2018. And this endowment then has carried through for these awards. And I'm pleased to announce our 2 award recipients this year, being Dr. Alan Scher of the Division of General Internal Medicine and Dr. Bill Altemeyer from the Division of Pulmonary Critical Care and Sleep Medicine. And to introduce these individuals, I just wanted to give some comments that were on the nominations. Dr. Scher is a professor in general internal medicine. She's also a member of the UW Medicine Diabetes Research Institute, located down at South Lake Union, and her focus is on obesity and diabetes in general, and she's well recognized for her outstanding contributions as a mentor. She also, parenthetically, also served or also was the first chair of the mentorship committee and created a mentorship committee in the Department of Medicine. So it comes full circle, and now you're getting the award. And some comments on her nomination include things such as she does an incredible job of explaining the process of academic medicine, setting me up with research opportunities as a mentee and helping me throughout. And she has helped me to find my power, my confidence, and to grow the way that felt right for me. And she also has noted for having a unique collaborative environment, which she brings out the best in her and the people that she mentors. So congratulations to Dr. Scher. I'll give both of them and then have you come up and get your certificates. Dr. Bill Altemeyer is a professor in the Division of Pulmonary Critical Care and Sleep Medicine. He's also the director of the Center for Lung Biology, located down in down at South Lake Union. So both of you are South Lake Union residents. And he's acknowledged as being a generous and accommodating leader through his position as director of the Center for Lung Biology. And he's also noted to be one of those individuals who creates a flourishing space and culture in which mentorship is woven into the fabric of the division and the Department of Medicine. And he also has an authentic approach to humanism. So I want to congratulate both Dr. Scher and Dr. Altemeyer. And if you can come up here, I'll have some certificates for you. And then the fund will be, there'll be access to the fund will be coming from our finance people. So use that $2,500. Sometimes people forget it's actually there. So congratulations. What? Bill, here you go. Here, stand in front. So congratulations. Here, stand in front. Bill, you want to say a few words, Bill or Ellen? You don't have to. Just congratulations.
Yeah, well, I mean, I'll say something. So I've known Bill Bremner for a long time. He was instrumental in my career development. And so I'm grateful to receive this award in his name. And I'm also grateful because I know there are a lot of great mentors in the Department of Medicine. I've benefited from many of them. So it's a real honor. Thank you.
I can echo that, and just a shout out to all my mentors and to my mentees who contributed letters to the division, Gitanjali and Tom, that supported me for this recognition. So thanks to all of you.
And Dr. Bremner sends his regards. He's actually down on South Georgia Island on an Antarctic trip. And so he sent me a picture from him today, but he says you both are highly deserving and he's very happy for you. So he sends his regards.
Thank you.
Thanks.